እየተነሳችሁ ራሳችሁን ለምድር ፍዳ እኛን ለስቃይ ኑሮ የዳረጋችሁ እናንተ ናችሁ። እናንተ በህይወት እያላችሁ ብርቅ ትሰሚያለሽ? በህይወት እያላችሁ በረሃብ በህመም እየተሰቃያችሁ ለሌሎች ማስተማሪያ መሆን አለባችሁ። ለዚህ ነው ዘሞች የማነሳውን ገንዘብ እንኳን ለእህትና ለወንድሞቼ የማረዳው እነሱን ረዳው ማለት እናንተን ከድህነት ነፃ አወጣሁ። ስለዚህ ቢኖረኝም ባይኖረኝም ብርቄ ቢኖረኝም ባይኖረኝም ለእናንተ ቤተ ሚስት ያደርጋል። ታዲያችን ልጅ ናት። ታዲያ ምን ይባል እንግዲህ ለነገሩ እኮ እውነት አለች። የልጆቹን ቢሆን የእኛ ችግር ፈጣሪች እኛ ሰዎች ስሜታችን መቆጣጠር አቅቶንም አይደል እንዴ የተፈጠፍናቸው። ብርቄ እሳት በጉያ ይዞ መቀመጥ ይቻላል? ሱሳቸው እና ሌሊት መንገድ ውስጥ ተገቢ ምን አለበት? እሳቱም እንጨቱም ያው የፈጣሪ አቅም ያላቸው ማለሊቱ ሙሉ ሲነዱ ቢያድሩ ምን ችግር አለ?
ችግሩማ ማማ እኛን የመሰሉ ለማኞች መተኪያ የሌላቸው በሽተኞች ራስ በራስ ወልዳችሁ ለእናንተም ብቻ ሳይሆን ለህብረተሰቡም ሸክም ማድረጋችሁ።
የአንቺ እናት ምንኛ ማጸና የተባረከ ነው።
ምን የተባረከ ነው? የተረገመ ነው እንጂ ምን ነው?
ስንት ወልደዋል?
ከኔ ጋር 8።
መተዳደሪያችሁስ?
ልመና፣ ሴተኛ አዳሪ፣ ስርቆት።
ቆይ አንቺ ምን ሆነች ነው?
ቤተሰቤን ልረዳ ጎዳና እናም ሴተኛ አዳሪ ስራዬ ካመጣቸው ብዙ ልጅ ጋር ተገናኙ። በመጨረሻም የበሽታ መናኸሪያ። በዚህ ሁሉ የዳረጌ ደግሞ የቤተሰቦቼ አናት ባናት መውለድ፣ በአፋቸው የሚጎርሱትን እንጀራ እጃቸው አለመመጠን።
ለመሆኑ በሽታሽ ምንድን ነው?
ምን ልበሎ?
የዘመኑ መሆኑ ነው።
አዎ እሰራው የነበረው ስራ ለዚህ በሽታ አቅም
ይሄ ሳባዎች የሚሉት ነው።
እዲያ ብርቄ ደግሞ ወተት ነጭ ነው ካላሉ አይገባሽ። ሲዘኛ ቋንት ማለት አይደለም።
ምን ነው ወተት የመድኃኒት አለው አልተባለም ነበር እንጂ ነው አንቺ ፈጠነብሽሳ። እዚህ ላይ እኮ ገና ወጣት ነች።
መድኃኒቱ የሚሰራው ከጥሩ ምግብ ጋር ብቻውን የሚለውጠው ነገር አይኖርም።
እስኪ እኔ ጋር ትንሽ ፍርፋሪ ያለች ላምጣልሽ። ሌላ እንኳን ምረዳሽ ነገር
እኔም ብሆን ያቺ ሩክና ልጄ ለአባቷ የላከችለት ጃኬት አለ ብርድ ይከላከልሻል አምጣልሽ።
መጠለያ አይኖሩትም እማማ።
የምታያት አንዲት ክፍል ናት። 8 ሰዎች እንዳሳኪት ታጭቀን የምናለው
በጠፋቸው ልጆ ቦታ ብተካስ በሽታ ሴል ያለ እሱ እንኳን በንክኪ የሚተላለፍ አይደለም።
ታዲያ አንቺ ከየት አገኘ?
እኔን የማያገኘኝ በግብረ ስጋ ግንኙነት ነው።
እንደውስ ልጆቼን ቢሆን አካለ በጣም ደርሷል።
አሁን የትኛው መልክ ይስማችኋልማ? አጽሜ ብቻ እኮ ነው የቀረው።
ንክኪው መጠጋጋቱ ሳት ይፈጥም የለም እንዴ? አይነት ሆን የባል የትኛው መልክ ስሞኝ ነው የሁሉ ልጆች ላይ በላይ ተፈጠፉ
እና መጠለያ አላገኘም ማለት ነው። ይኖረ የምንገደው
እስኪ እችን ያዥ ልጅ
አውስተኛ
የደገፊ ሆነ ያላችሁ የታወቀ ነገር የለም። ወደ ነካካው ብቻ ምግብ ነው።
እቺ ኖራ ወጫት ወይ እሷን ትብላው
አይተ ያዥ ብርቅዬ ያዥ እንጂ ደግሞ ምን መግደርደር ነው?
ቢናቴ አፈርለምታ እኔነት እርሶስ ለአዳር የምትሆን ትንሽ መጠለያ እንጂ ምንከሽ እንዴ ምን የምትለው ቢበቃ እኔ ምንም አንቺ እኔ አትንጌ ነው ያቻለ መሪዋን ካለ ነው እኛም መደረጃን ተጋይሮ ማደረ ጀመር ነው እንጂ እኛም በፈረቃ ነበር የምንተኛው። ኦኬ ሰሚያለሽ ጉድ ወደጅ እናት ወዳም አይደለም ቤቢ እግዚአብሔር ይስጣት። ኧረ ቢዩ ምን ማለት በላለሽ? ይበቃኛል።
ምነው ራበኝም አላልሽ?
አይ በቃ አልበላልሽ አለ።
እስቲ እንጂ ወንጫጭራ
ይህን እንኳን ባይሆን መንገድ ላይ ከጠማኝ ጠጣዋል።
ይዛችሁት
እግዚአብሔር ይስጣችሁ። ባደረጋችሁልኝ እርዳታ እግዚአብሔር ብድራችሁን ይመልስ። አመሰግናለሁ።
አንቺንም እግዚአብሔር ይማርሽ።
እግዚአብሔር ይማርሽ። እማ
አቤት
ደህና ዋሉ።
ደህና ዋሉ። ደህና ብርቄ ነሽ ወርቄ ያቺ ማለት የተጠራ የነበረ አይነት ፈጠራል ይጠራል
እንግዲህ አንቺ ደግሞ በትኛው ሰማያት ማለት ሰብስበሽ ለትንሹ ለትልቁ ኮሌራ ባላለው ያለ
ወገን የለም እንዴ? አዛኝ የለም እንዴ? ሐኪም የለም እንዴ? ከማናት ደግሞ በጊዜ የዱታኛ እባክሽ እስኪ መጀመሪያ እንናጁ ኧረ እባክሽ ሊሆንልሽ የሚመጣው እባክሽ ቶሎ በይ ኧረ እባክሽ ኧረ እባክሽ ኧረ እባክሽ አሁን ወደዚህ ስመጣ ከእኛ ጋር ተዘርፏል መንገድ ወስዳ የሚቆጣልሽ ተጋድማለሁ። ጉድጓድ ውስጥ ተሳስቶ የገባሽ መስሎ ለአውጣ ጠቃስት ራሱ ተመጃገተ እንታይች እንዲያውቀው የለም መጀመሪያውን ቅልፍ የወሰዳት መስሎ መጀመሪያውን ቅልፍ የወሰዳት መስሎ ቀደም ሳይፈጽሞ ትንፋሽ አለባት። እችን ወረቀት አድራሽ ይሆናል ብዬ ነው የሚባል ላይ እናስቀምጥ ያያዶር ብዬ ከዚህ ስትሆነ ማንበባች ማነች ሚጣይ
አቤትማ
ነስኬንያ እቺ ነው
ስለሆኛል እኮማ
የአባቷ ይዘውሽ መጣ እስቲ ምንድን ነው ምንድን ነው እሱ ማንበብ ማቃተሽ ሚታቶላችሁ ምንድን ነው
እና ምን ብዬ እንደምጀምርልሽ አላውቅም። ትምህርትን አውቃቼ መንገዳን ሴተኛ ዳርኩት እናንተ ቤተሰቦቼን ለመርዳት እንደሆነ ታውቃላችሁ። ለተወሰኑ ዓመታት ዓለሜ ተሳክቶ ለቤተሰቤ መጠነኛ ድጋፍ ሳደርግ ቆይቻለሁ። አሁን ግን ከስሬ ጋር ቀይሁን ላለው በሽታ ተጠቂ ሆኜ ይህን ደብዳቤ በምታነቡበት ሰዓት ምናልባትም በሞት አፋፍ ላይ ሆኜ ይሆናል። ዛሬ ጠዋት ናፍቀሽ ለማየት መጥቼ ነበር። እኔ አየሁሽ፣ አንቺ ግን አላየሽኝም ነበር። የመጣሁት ቁርማ እንጀራ ለምንሽ ነበር፣ አልነበረሽም። ጎረቤትሽ የሚጣናት የሚጠጣ ውሃ ጠጣችኝ። መጠለያ ጠይቄሽ ከለከልሽኝ።
ኧረ ማለት ወርቄ ምንድን ነው ለሆናችሁ ወርቄ አንተ ነህ? አራት ቆይ
እኔ ነበር የፈለኩት ከእናንተ ከተለየሁበት ከቤት ከወጣሁበት ጊዜ ጀምሮ ከዩኒቨርሲቲ እንኳን ላገኘው የማልችለው ህይወት በተጨባጭ አስተምራኛለች እና ለጊዜው የምልሽ ነገር ባይሆን ሰላሙን ሁሉ አንቺ እመኝልሻለሁ። ከአንቺ ልጅ ጽናት
ስለዚህ ልጅ ሞት ተጠያቂ ሰው ማለት ነው። የዚህ ልጅ ሞት ተጠያቂ ማለት ሰው ነው ማለት እናትና አባት ትራንስፖርቱ ካራቆ ህፃናት ማለት ቢታችን
እነሱ ትልልቆቹ ያለገባቸው እኔ እንዴት ብዬ አውቃለሁ?
ልጅቷ ሞት ተጠያቂ እናት፣ አባት፣ ወንድም፣ እህት፣ ጎረቤት ካልሆነ ማን ነው? እስኪ ከእናንተ ማለ ነው ወይ ማን ነው ይሉኛል? እርሱ ዋቁርሱ ነው የጠበቁት። የልጅቷ ሞት ተጠያቂ መልስ የለው። አረባካችሁ መልስ አለ። በጣም ይላል መሰለ አባቱ ማን ነው? የልጅቷ ሞት ተጠያቂ ህብረተሰቡ ነው እያሉ ህብረተሰቡ ብቻ በቂ ነው። ህብረተሰቡ ብቻው ምን አጠፋ? ሌላውስ እስኪ እናት ማለት ነው ጎረቤት፣ ቤተሰብ፣ ህብረተሰብ ያው ሰው ላይ ያለ። ስለዚህ ለዚህ ሞት ተጠያቂ በአጠቃላይ ቤተሰብ ማለት ህብረተሰብ ነው። ህብረተሰብ ነው ብቻ ብለን ዝም እንበል? እኔ ግን አይመስለኝም። ለልጅቷ ሞት ተጠያቂ ቤተሰብ አላት ህብረተሰብ ነው ብቻ ብለን ነበር። እናት ማለት ነው አመሰግናለሁ። ለልጅቷ ሞት ተጠያቂ መንግስት ማስተዋጽኦ አይግባባንም። በሀገራችን መሰረተ ልማት ባለመሟላቱ የጤና ተቋማት ባለሙያዎች ዛሬ ሞታለች፣ ነገ ይቀጥላል። ሌላ ሰው እናት አባት፣ እቤት ውስጥ ያሉ 8 ህፃናቶች፣ እቤት ውስጥ ያሉ 5 ህፃናቶች። አሁን እያየን ያለነው የእነዚህን ቤተሰብ ብቻ ነው። የሌላውስ ይህ ታሪክ ነግበኔ ነው። ዛሬ እኛ ታሪክ ነው ብለን አቀረብን ይሆናል። ግን ሁላችን ቤት ሊያንኳኳ የሚችል በሰፈራችን በአካባቢያችን እንዲሁም በሀገራችን ላይ ያለ እየተሰራፋ የመጣ ችግር ነው። እስኪ አንድ ሰው ሌላ ነገር ልትሉኝ ካለ ለድህነት ተጠያቂው እኛ ራሳችን ነን። እኛ ራሳችን ባለጣለው ችግሩ እየተከሰተ ይገኛል እያለች የሚያስማማ ነው። እስኪ ሌላ እንደታሰብ ወደኋላ
በእያንዳንዳችን በሰፈራችን በቤታችን በአካባቢያችን የሚከሰቱ ነገሮች ናቸው። ይህንን ለማጥፋት ግን ሁላችንም በአንድ ላይ ቆመን የዚህን ጥፋት ማገድ አለብን። መንግስትም እኛም የሁላችንም የድርሻችን ተቀበለን ካልሰራን ይሄ ስር የሰደደ ስለሆነ ሊጠፋ አይችልም። ስለዚህ ሁላችን
አዲስ ሁላችንም ጥያቄ ያለው ግን ስለጠየው ይመሰግናል። ወጥ ማለት ዋናው ጥያቄ ምን ጥያቄ የሚሆነው ቤተሰቡ ወደቱ ማህበረሰቡ ይሆናል። ስለዚህ እኔ እንደማስበው እኔ እንደምታይ በዚህ ሁሉ ዋናው በጥያቄ ሆኖ የሚታየው ድህነታችን ይሆናል። አመሰግናለሁ። እሺ እንግዲህ ድህነታቸው በተለያየ ካሄደ ድህነት ማሸነፋቸው ነው። ድህነት እንችላለን በማድረጋችን እንችላለን። ሁላችሁም ያቀረባችሁት ሀሳብ ትክክል ተገቢ ሆነ። ስለዚህ ይህ ነገር ነጋሪ ነው ብያለሁ። ሁላችንም ልናስብበት ልንጠነቀቅበት የሚገባ ጉዳይ ነውና ትኩረት ልንሰጠው ይገባል። አደራ አደራ እንላለን። እናመሰግናለን።
This is the drama of people to people has stayed there, and as a young man, the playwright, renowned person, he has taken this responsibility and trained this drama. So I would like also to ask, to express your appreciation to Ato Hayal Mulat, please. I think it will be difficult to express all these things within this short duration of time, so some interpretation you may have gained some, what's it? The next program, the next session, presentation session will be facilitated by Dr. Tavich Bishop, chairman of this organizing committee of this conference. But before that, I would like to call upon Dr. Nauro Mari, the President of People to People. He will come here, but before that, I think I shouldn't pass this opportunity, at least since it's important. We have to also to encourage him. He's very, very tireless person. He's working day and night, and because of his initiative and his hard work and the group of people to people, this has come to fruition. So Dr. Inaugo this year has won the prestigious award, that is the American Academy of Neurology of 2010 award. Please, Dr. Inaugo, stand up. Please appreciate when hard-working people achieve to this global level, this also will be an encouragement for all of us to work hard. If we work hard, we can change any situation, As it has been shown in the drama, poverty is the outcome of so many problems, but if we work hard, if we come together, if we be hand in hand, we can change the situation. Now, Dr. Rinaldo, please come and introduce the other person.
Thank you, Atuanis, for your generous introduction. That's something that I didn't expect to say. I just want to say one thing to introduce to you. This morning, we missed one part. Alice and Shiko was here about a year ago. And they were working on a documentary film. In fact, they went to Gojam, I think in North Salam area, and they prepared a documentary which outlines the lives of women who were victims of obstetric fistula. And that documentary film got Emmy Award. And Emmy Award, as you know, is a very prestigious award in the world. And we are fortunate to have someone, an American, who comes to Ethiopia, lives the life of our sisters, and presents that story to the rest of the world. And people to be very fortunate to collaborate with such individuals, and I'm glad that she's here. I want.
Thank you so much, Dr. Mahari. And it's, again, such an honor to be here. And as I was saying before about Dr. Hamlin's work, as it's inspired countless others, it's inspired us. And as Dr. Mahari said, I was here working on a film about obstetric fistula 5 years ago. And now I've started an organization in the U.S. called Healing Hands of Joy to continue to work with women that have obstetric fistula and help them with reintegration, help them have a second chance in life, and help them with preventing fistulas in their village if possible. So I just wanted to thank you, Dr. Mahari, and everyone else that has come and has been involved in our project as we've been developing it, because we really depend on Ethiopians, on you for guidance as we grow the program. And thank you again for being here today. And thank you again for Dr. Hamlin for attending. Okay. Thank you.
Now, starting from this time, Dr. Talbot will be facilitating the session, and the moderators and the presenters will be coordinated by her. Thank you for your kind attention.
Thank you, Dr. Hines. Now we have gone through the introductory sessions and also have seen this wonderful drama telling us a lot about our life situation. It is the reality that we are living in, and it has brought home lots of thoughts and reflections on the kind of society and problems that we are living in. The following session will be dealing with technical presentations. Immediately now we'll have a session on maternal health. There will be 3 presentations. One will be on reproductive health. It will be presented by Mr. Usrat Belaine and moderated by Sarah. The second one will be on maternal mortality reduction. Will be presented by Dr. Mangistu Hailemariam, moderated by Dr. Metin. And the last of this session would be Women and HIV/AIDS, presented by Dr. Osuke from APCO and moderated by Fuad or his representative. After we have heard the presentations, there will be a panel discussion in which we also have a couple of discussants to add on the reflection of what their thoughts are on the subject. Now I will leave the floor and call upon Sarah to lead the first session. Thank
you. Good morning all. My name is Sarah Haile. The program has my name a little bit spelled wrong. To just introduce myself, again, I'm Sarah Haile, a public health professional who has worked in the field for about 12 years in the US. I recently came to Ethiopia 5 months ago. I'm a volunteer with American International Health Alliance and placed at Tukur Ambassa Hospital. And now it's a great pleasure of mine to be here with all of you in the audience. Dr. Hamlin actually delivered me 37 years ago at Lil Tsahai Hospital. I just wanted to tell her that she did a good job. And now it's a great pleasure of mine to introduce Yemisrach Belaine, who's a country advisor for Packard Foundation. So everyone, if you can welcome Yemisrach Belaine, who will be presenting on maternal health in Ethiopia. Thank you.
Good morning again, and I really want to thank People to People and the organizing committee for giving me this opportunity to share with you a few points about family planning and women empowerment. And before I proceed with my presentation, I also want to thank the youth artists who really set the stage for my presentation and also the discussion that we're going to have today. Saying that, maybe a little bit of correction on the agenda is, it says the perceived impact of, the perceived implications of family planning on women empowerment. And please note that it's not perceived. You know, the impacts of family planning and reproductive health for women empowerment in different aspects has been tested, researched, and also told by millions of women. So let's take it that, we're not going to create a new science, but rather share with you what has been done in the past. So, today, as has been said by the Minister, by His Excellency Dr. Tedros, the Minister of Health, and other speakers, this conference is very timely because in Ethiopia, we just finished celebrating a whole month of safe motherhood, in which we discussed about not only safe motherhood issues, but also other women empowerment issues as it relates to women. So I also want to thank People to People for continuing the discussion on this issue. My presentation definitely will focus on family planning, which is one of the effective ways to empower women. And as I said earlier, it's not a new technology to the world, or most of you here represented in this audience. Yet, unfortunately, millions of women globally and also in Ethiopia are still seeking family planning services. So we really need to work more and also make sure that the services are expanded to reach the women in rural and urban areas in Ethiopia. The purpose of my presentation today is, one, to remind us all about the impacts, both health and non-health benefits of family planning, and also help us renew our commitments in different ways to increase access for family planning services. And then I also want to focus on how we can engage the diaspora and people's, friends of Ethiopia in helping us achieve this important objective in our country. So why family planning, and in particular, its contribution on women empowerment, as today we're discussing on, empowering a woman is empowering a nation. As most of us know here, family planning is a unique intervention among medical inventions in its potential benefits to women's health, family well-being, and overall development of a nation. Family planning has both medical and non-medical benefits, which have high contribution for empowerment of women and reduction of poverty at national level. So in this presentation, although the benefits are many, I will be limiting my time to focus on the health outcomes, economic and gender equity issues as it relates to the empowerment and development of women. Before proceeding with our discussion on the contributions of family planning towards improving the social and economic well-being of women, and contributions to the overall development of a nation, I want to pause and reflect on the context in Ethiopia as it relates to the health of women. This slide is taken from our recent campaign on Safe Motherhood Month in Ethiopia. And these figures are very powerful. I'm not going to read these figures for you. Most of you know them, and you can also see them. So it is, translated in terms of every hour, what happens in Ethiopia as, as it relates to women's health and particularly maternal health. So when you look these numbers, I also want to urge you to look beyond the numbers. Beyond these numbers, beyond individual women, there are many people, families, and the nation that depends on these women. So when we're talking about the health of women, we're not only talking about the individual women, but rather the family, the community, and the people at large. Well, in Ethiopia, we have registered a lot of developments in improving women's health. And just to give one example, if we take the case of maternal mortality, between 2000 and 2005, we were able to reduce the days per 100,000 lives from 871 to 673. And today, we believe that it has been reduced even further. However, although there are a lot of good achievements, we will have a long way to go if we are to achieve our national goal and the MDGs targets that we say to achieve by 2015. So I want to take our discussion today in light of all these issues that I have mentioned earlier. So what are the health benefits of family planning? Just to mention a few. The benefits of family planning for the survival and health of mothers and children are many. The health benefits of family planning can be seen in many ways. In this regard, one of the strongest arguments for family planning is its contribution to reducing maternal mortality and morbidity. I know that we're going to have a session that deals entirely on maternal mortality, so I will not take your time on that. But just to give you, some important issues, points, family planning prevents as many as 1 in every 3 maternal deaths by allowing women to delay motherhood, space births, avoid unintended pregnancies and abortions, and stop childbearing when they have reached their desired family life. As a result, family planning is considered one of the most important pillars for reduction of maternal health, in addition to skilled delivery and also expansion of emergency obstetrics care. Secondly, family planning also reduces newborn, infant, and child death. This is possible because family planning enables women to space births and also give a period for the woman to recover physically and psychologically from previous pregnancy and birth. The space will also allow new infants to get appropriate care and nutrition from the mother and the family at large. The other benefit of family planning is also it saves and improves the health and development of adolescents. As we all know, young people will get a lot of benefits. Sexually active young people and adolescents can get protection by using family planning methods from unwanted pregnancy and early childbearing. As most of us know here, teen pregnancy is one of the major challenges globally, and its consequences are detrimental for millions of young girls. In Ethiopia, the median age at first marriage for women is 16 years. And this is particularly true in rural places where 85% of our population is living. We still have a high percentage of early marriages happening in the rural part of the country. So one of our interventions is to stop early marriage and to encourage young girls to stay more in education, to stay more years in school. However, we're not able to achieve this always. Still, young girls continue to get married at an early age. So how do we protect them from early childbearing and also give them some time to grow in their education and personal development? So the contributions of family planning in that respect are also very big. In addition to preventing unwanted pregnancy, condoms play dual purpose. Consistent and proper use of condoms reduces the rate of HIV infection. And also, condoms protects sexually transmitted diseases. Different family planning methods also help HIV-positive couples to avoid becoming pregnant and thereby reducing the risk of HIV/AIDS transmission to newborns. We are still looking into the health benefits of family planning, and perhaps one of the least talked benefits of family planning is its contribution for personal and emotional wellness of women and families. Reproductive health is defined as, I quote, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity in all matters relating to the reproductive system and to its function and process. Unfortunately, whenever we talk about family planning, we only focus on the medical contributions, and we think of the physical morbidity or mortality that will come as a result of unplanned pregnancy or consequences of pregnancy. Yet, it's also important to focus on the psychological wellness and health of the women and also the family. In this regard, family planning, when women exercise family planning on their choices, a lot of them report that it reduces stress that will be caused as a result of unplanned pregnancies or consequences of pregnancies. Women from both developed and developing countries have witnessed using contraception to time births and avoid unintended pregnancies gave them a space of control over their own life and family matters. Women reported greater self-esteem and satisfaction, less stress, and more leisure time, which they can enjoy alone or with their partner. And ultimately, this will result in the happiness of the women, the family, and the community, and also brings harmony to the household. So this is another important area where we need to think the contributions of family planning empowers women and empowers the household and the community. If I said a little bit about the health benefits of family planning, then I want to shift your focus on the economic benefits of family planning. Family planning has a direct contribution to the economy, both at the household and national levels, from which women are always vulnerable. Households with many children are more likely to face difficulties in meeting the day-to-day needs of the household, and I don't have to say much, as the drama has clearly shown us the lives of many Ethiopians in this, or other people in developing countries and even developed countries. In the context of poverty, large families are usually less well-nourished and less well-educated compared to smaller families. And in all cases, the majority of the responsibility looking after the food and other needs of the family rests heavily on the women. As at the national level, countries that invest in family planning can reap immediate health benefits, investment savings in the health and education sector, and social and environment benefits. So by limiting their family size, couples will enhance their capacity to provide better, and also it promotes health and education services. And more importantly, as I said, it increases productivity among women and boys and girls and women. The last point that I would like to reflect is the gender equity. Family planning also plays a lot in terms of ensuring gender equity. To begin with, family planning, enabling women to exercise her right to decide the number and time of her children is a human right issue. So by expanding family planning services, we are helping women and couples to exercise that right. It also enhances decision-making because it relieves women from repeated births and thereby gives them more time to participate in the other activities at the household level. And more importantly, it improves social position By social position, I mean women's role and involvement at the community level, and also their participation in political spheres. These are really contributed to the family planning, the outcomes of family planning, by enabling women to have more time and space. So finally, before I conclude, I have about 4 minutes or 3 minutes, I just want to pose a few questions in terms of what will be the role of the diaspora and people's, friends of Ethiopia in supporting us and also the programs here in Ethiopia. So the first point I would like to suggest is support implementation of policies and guidelines. As we have heard earlier in the morning from the minister, we have a lot of policies in this country that really contribute to the empowerment of women in all aspects, be it health, economy, or gender equity. We have a lot of policies, and I have mentioned a few. But the major gap is implementation. And this gap is not only financial, it is also technical and human resource. So what can be the role of the diaspora in helping the country and the governments to meet these objectives and also implement these policies? The second area that I would like to propose is be advocate for family planning. In the past few decades, family planning has been taken from the agenda of the international development movement because of other issues that came as an important issue, and somehow family planning was taken aside. And this including HIV/AIDS and different development agendas, and policies have pushed family planning to take side in the international development agenda. So the diaspora and friends of Ethiopia getting the opportunity to participate in different in different international conferences and forums, they can help us to really reposition family planning and make it one of the development agenda in these forums. So that is one area where you can help us. Another area is call on donors to honor pledges. Usually in these big international conferences, donors pledge for family planning services, but usually the money would not come. So we need someone to follow up and make sure that these investments are actually happening. And thirdly, they can also mobilize resources when aspects. And finally, educate, mentor, and be a role model. Thank you very much.
Good morning, everyone. My name is Madhen Zaudu. I am from the Federal Ministry of Health. And I would like to thank people for organizing this important conference, which is a very important area of intervention for all sectors, including ours. Actually, the Ministry of Health, as you know, has been implementing the Health Strategy Development Program Phase 3 as part of the poverty reduction strategy. And right now we are concluding the Phase 3 strategy and heading to the development of the 4th stage of the health sector development program. And the major focus or components of the HSDP3 has been maternal health and child health. And likewise, this will remain as important areas of intervention for the next 5 years to reach or to implement the MDG targets as it has been described earlier. So in this area, Dr. Mengistu, then I should pause, Haile Mariam, not the Mengistu Haile Mariam, will be presenting to us as to what we have been doing in the past 5 years in the area of maternal mortality reduction. And I please welcome Dr. Mengistu Haile Mariam, and I kindly ask him to stick to time as we are beyond schedule. Thank you.
Thank you very much. You see, in many occasions when my name is mentioned, everyone appears surprised. But I can assure you that I have nothing to do with the one living in Arahare, okay? Thank you, Dr. Madden. It's really a great honor and pleasure to be with you today here, just to share maternal health situation in Ethiopia, representing my ministry, Federal Ministry of Health, and I am really happy to be with, especially with Dr. Hamlin, my teacher, and also the best surgeon, Mamit. She is also my teacher while I was a postgraduate student in Fistula Hospital. And I would like to thank People to Pupil for organizing this occasion and to talk about maternal health, especially just following our Safe Motherhood Month. Okay, in the following minutes, I've been given 15 minutes, and we'll talk about probably, I will give you some background information, and just to refresh your recollection, I will say a few things about maternal mortality and things depicted over there. You know that the new census shows the Ethiopian population has reached 77 million, and the nation is federally structured in highly decentralized districts. We have 9 regional states, 2 city administration, and our total fertility is hovering around 5.4. Just to refresh your recollection on these maternal days, according to the International Code of Disease, maternal days is defined days of a woman while pregnant or within 42 days termination of pregnancy, regardless of the duration and site of pregnancy. And if you say a few things about measure of maternal mortality ratio refers to a number of maternal days during a given period of time per 100,000 live births. This is the most commonly used measure of maternal mortality, and it really shows the risk of death while a woman has become pregnant. The other one is, which is less commonly used in many literature, is maternal mortality rate, and it shows still the number of maternal deaths in that very period, but the denominator is it's 100,000 women of reproductive age period. And the other is lifetime risk of maternal deaths. It is just a cumulative probability of dying as a result of pregnancy within a woman's reproductive age. So if I say so, what causes maternal deaths globally? Let's see. You know, the first to come is severe bleeding, especially in the form of postpartum hemorrhage. Usually in our situation, mothers deliver at home, and if there is bleeding, and if that bleeding is not stopped, then that can really kill them. You know, the lifespan is only 2 hours. Unless we act fast, usually mothers, you know, will be lost within 2 hours. So this is the hard fact is, even in Ethiopia, most mothers are dying as a result of this severe bleeding. The other proportion of causes as depicted in the slide. And there is what you call the 3D model, which has really contributed a lot to the cause of this maternal death. And it's widely used in the context of the globe, just to understand or to comprehend and investigate the complex social, cultural, and medical events contributing to the maternal death. And these delays are delay in the decision to seek care, usually in the home. When mothers are in labor, they usually contemplate to go to the nearest health facilities. And the other delays are delay in arrival to an appropriate medical care and delay in receiving adequate care once a woman arrives to the medical facility. I'm sure most of you are well aware about these delays. So, you know, pregnancy is actually a physiological condition, but, you know, 40% of women unfortunately experience complications during pregnancy, childbirth, even in postpartum period. And still, to make things worse, out of this 40% of the pregnancies, 15%, you know, can lead to life-threatening situation like death. So if you just compare, you know, the situation of these maternal deaths in Ethiopia and somewhere in Europe, the lifetime risk of a woman dying from pregnancy-related causes is 1 in 16. This just in contrast to in Switzerland, it is, as you see, so it is very shocking. It's mostly said about this MDG, and you know that this is a kind of set of commitment agreed upon by many nations in the globe to be involved actively in developmental activities. And the aim of Millennium Development Goal 5 is to reduce maternal mortality by 75%. This was signed in 1990 Gregorian calendar, and by then UN has estimated that the maternal mortality ratio in Ethiopia was 1,068. And the first Ethiopian DHS estimates it was 871 per 100,000 live births, and our target is 267. Can you reach it? Can you do it? It is really a severe and throbbing headache. And in fact, the DHS 2010 is in the process, and I know that it will be started next September. So we feel that there could be some reduction in maternal mortality ratio in the upcoming survey, but still we feel that we are still lagging behind and we are far away from the target. So let me show you this figure, this graph. You know, this graph just shows that if you go like business as usual, or like that we have been doing, you know, we will never attain our Millennium Development Goal by 2015. So it is high time, and we think that it is high time to think twice, to sit down and think twice in order to accelerate our efforts in terms of reduction of maternal mortality. So the blue shows that, you know, if our efforts are going like this, you know, the reduction would be more or less stagnant. But the red shows that we can, if you can have a concerted effort, or if there is coordinated action from every corner, then we'll be able to attain the Millennium Development Goal. So let me give you some facts at the ground right now. I have just collected these figures from the routine report in the Federal Ministry of Health, but this is just a bit greater than I know from the DHS 2005, but the report shows that the contraceptive acceptance rate in Ethiopia, you know, reached around 56%, and the antenatal care coverage, which used to be our big headache, and it still continues to be our problem, but we feel that we are reaching around 66%. Skilled birth attendant, including those attendants handled by the health extension workers, reach around 24.9%. But those deliveries handled by skilled birth attendants are still below 5%, according to DHS 5. And I cannot tell you that we are in good track regarding emergency obstetric care. We are still far lagging behind as far as our emergency care to mother is concerned. So this is a fact. So where is our challenge? The previous presenter has showed you that every minute this figure of mothers are dying, and so on and so on. That has been drawn from this yearly report, which shows that we have 2.8 million births every year, and unfortunately, because of these pregnancy-related causes, 25,000 maternal deaths are occurring in this nation. And our beloved newborns, kids, around 118,000, and disabilities, especially the long-term obstetric disabilities like fistula, it is around 500,000. So it is really a big challenge, and it's shocking, especially for those of you coming from outside of the health sector. So this is, so the other, what causes this problem? You know, I was happy when the previous speaker was talking much about family planning. If I tell you some fact about this family planning in our situation, the rate of unintended pregnancy or unplanned pregnancy in Ethiopia is around 34%. And maternal deaths are, it's higher. So if we can provide or if we can reach even those unintended pregnancies, we can avert 1/3 of the maternal deaths load in Ethiopia. So we need to work hard, especially in the area of family planning. So far we have some sign of achievements in this regard. For instance, it's been said earlier even by His Excellency Dr. Tedros, we could have a big army of these health extension workers, and using this army, especially at the grassroots level, we could, double the contraceptive prevalence rate. It's more than twice, okay, according to the last 10-kilometer survey finding. And the other one is the government is committed to take, the initiative to disseminate or to target 3 million women to take this long-term contraceptive method. That's a kind of subdermal implants, which is called Implanon. It is used for 3 years. And there is, in fact, a massive training on the line of long-term and permanent methods of contraception in collaboration with our partners. And in this regard, we are registering really a good result. Even if I tell you the results of our previous Safe Motherhood campaign, insertion of Implanon and giving this long-term contraception was one of the elements in the Safe Motherhood campaign, and we have reached quite a lot of mothers in need. The other one is, as I've told you earlier, the low-skilled birth attendants, we are still below 5%. So in this regard, we are doing things, especially we are focusing on IAC, BCC tasks using these health extension workers. And as been said earlier in the morning, there is a rapid and fast expansion of health infrastructures. And we are these days empowering the health extension workers to deal with PPH. Earlier in routine or in professional trainings, PPH can be tackled using some uterotonic drug like oxytocin and ergometrin, but these days the government has adopted a kind of drug which is called mesoprostol, which can be taken per os and can be administered by low-level health professionals, even by health extension workers. So we are doing a great deal of jobs in this regard. In human resource, we have a dire shortage of human resource in the health sector, and even those we have them in the sector, there is higher turnover. So in this regard, there are a lot of jobs as depicted in the slides. I'm just rushing against the time. And the other one is emergency coverage of obstetric cares. So still, we had one opportunity. That is, the national EMOC assessment was done and released a few months ago, and we now have the concrete data where our gaps are. So we are doing to fill those